Hi, everyone. Welcome back to the Breast Cancer Podcast. Hello, I'm your host, Dr. Deepa Halaharvi, a fellowship trained breast surgeon, and also happen to be a breast cancer survivor, thriver, and a warrior, living my best life. As you know, breast cancer affects millions worldwide, touching lives in a profound ways. Whether you're someone facing a diagnosis or a supporter seeking information or just eager to learn more, this podcast aims to be a beacon of understanding, hope, and empowerment. I'm here to talk about all things breast cancer, from surgery to survivorship, as well as high risk for breast cancer to metastatic breast cancer. My goal is to provide you with reliable information, share inspiring narratives, and foster a supportive community. I know firsthand the challenges breast cancer diagnosis brings. Throughout this podcast, I will give you strategies to handle difficulties that arise from cancer diagnosis. We'll have insightful conversations with medical experts, researchers, survivors, caregivers, and advocates. I will tackle topics that impact our lives as cancer survivors. My goal is to educate you and empower you to live your best life. I definitely have. Well, let's get started. Right. Hi, everyone. Welcome back to the Breast Cancer Podcast. I have the Dr. Anita Somani here. I feel so honored that I'm sitting right next to her. And she's this phenomenal OBGYN and also
State representative.
yeah, and she's doing incredible work here in Ohio, and I'm super grateful that she is here. And I thought it would be fabulous to have her here on the podcast because a week after Mother's Day, it's considered National Women's Health Week, and we celebrate that every year.
Yeah.
And the theme of this year, it's usually, CDC comes up with a theme for every year, I guess, which I didn't know. I learned something new. But this year's theme is Women's Health, Whole Health, Prevention, Care, and Well-being. So I think it's really fantastic to have you here. Some of the barriers women have, in terms of getting good medical care, delay in diagnosis because
Right.
sometimes they feel like, their doctors are not hearing them. Maybe their pain is not being managed as well, or they're misdiagnosed. There's racial bias. There's not as many women in research
Right.
projects. What are some other things that you think are difficult for women?
Well, sadly, I saw all of that in one patient recently.
Yeah.
A patient that was referred to me, 7 years of having abdominal pelvic pain, cramping, and just got dismissed. And it happens so often.
Yeah.
When you think about women dealing with painful periods or women dealing with heavy bleeding. And some of it is genetic because things like fibroids and endometriosis run in families.
Yeah.
And so oftentimes mom will say to her daughter, everybody in our family has painful cramps. That's just normal.
Yeah.
And so that's one way that, the pain is dismissed or undertreated because it is, so many of those conditions are genetic.
Yeah.
And so people end up saying, well, we all have that. That's something you have to deal with. But I think that what I often tell people is, if you get medical treatment and it doesn't help, then you need to figure out why.
Yeah.
Right?
Yeah. Yeah.
I mean,
Exactly.
It's very simple. If something isn't working, if it's not improving things, then you do need, whether it's imaging like an ultrasound or further testing, so that there isn't that delay in diagnosis.
Right. No, I
Yeah.
think it's important for women to be their own advocate.
Yeah.
And if they do not connect with the physician, or if they feel the physician is not listening to them or the provider is not listening to them, I think it's important that they seek maybe a different person
Right.
and feel heard.
Right.
I think it's terrible to feel like you're not being heard. And there are, also a lot of reproductive health concerns. What are some things that you have seen in your own practice in that aspect?
Well, I think we're getting more attention being paid to things like polycystic ovarian syndrome. In the past, that was sort of taken for granted, like, oh, it's a condition where, women have irregular cycles or they have acne or they have facial hair. But we do recognize now, or we do understand that women who have polycystic ovarian syndrome can also have problems with fertility,
Yeah.
or later on can have issues with diabetes or hypertension. So it becomes important to address those issues early on. The other thing that I think we're learning more and more about is that some of the things that happen during pregnancy can impact your health later on. So
Yeah.
women who have pregnancy-induced hypertension are more at risk for hypertension and cardiac issues later
Later
on
in
in
life.
life.
Yeah. Yeah.
So making that connection, being able to get that history as physicians
Yeah.
to say, oh, you had problems with high blood pressure during your pregnancy, let's start screening you earlier, or let's be more aggressive
Yeah.
about treating you so that in the end, you're going to have better care, that
Right.
you're not going to
Right.
progress to, when you look at hypertension, you're not going to progress to kidney disease, or you're not going to progress
Yeah.
to having problems with your vision. There's so
Yeah.
many things that can happen.
Yeah. Yeah. No, those are all really great points. And, when we talk about risk factors for cancer, some of the things that come to my mind is like using alcohol, tobacco, preventable risk
Yeah.
factors,
Yeah.
obesity. Obesity is a big, huge problem in America. 42% of men and women are obese, and then 25% of young adults are obese.
Right.
And that's a really, really big problem, which can then later on, result in diabetes, heart disease, and cancer, metabolic syndrome, neurodegenerative diseases. So the list goes on and on.
I think one of the problems, though, is that there is this issue with fat shaming, right?
Yes, absolutely. Yeah.
Where people are sort of afraid to go see a doctor because they don't want to be fat shamed.
Yeah.
Or they don't want someone to say, all of your problems are due to your
Yeah.
weight.
Yeah.
And
Yeah.
I think we as physicians sometimes don't look at the impacts of what we call the social determinants of health,
Yes,
right?
absolutely.
Like, we don't ask, like, do you have the capacity to get fresh fruits and vegetables? Or what is your diet like? Or look at them more holistically.
Yeah. Yeah.
Because it's very easy to say, you know what, you're fat, you need to lose
Yeah.
weight,
Yeah.
and you need to exercise more, and
Yeah.
you need to change your diet.
Yeah.
But the practical aspects of that are challenging for
Yeah.
many people.
Yeah.
If you live in a food desert, or if you don't have access to fresh fruits and vegetables, or you don't know what the impact is because you grew up in a house where people were doing like processed foods or ultra processed
Yeah.
foods and fast foods, you may not have any idea how
Yeah.
that's impacting your health. So I think, again, it comes back to us, whether you're in primary care, you're a specialist. I mean, you're
Yeah.
seeing people
Right.
after, like, we as gynecologists have made the diagnosis, or
Yeah.
we've done the testing and then send them to you for biopsy. But I think starting early on, with pediatricians, with family docs, for us to be able to look at people and say, hey, tell us a little bit about your diet. Those open-ended questions that
Right.
in medical school we were taught to
Yeah.
do, but in practical purposes, we're
Yeah.
like, do I have time for an open-ended
Yeah.
question?
Yeah.
And
Yeah.
we hurt ourselves in some respects when we're
Yeah.
trying to rush through a visit.
Yeah.
So I do find that asking those a little bit more open-ended questions, and people generally won't go on.
Yeah.
They understand there's a time factor.
Right.
So,
Exactly. And also, it's so much easier to buy a hamburger than to get it in a bowl
Yeah.
of salad, right? It's more
Well,
expensive.
cost,
Yeah.
it's cost prohibitive
Yeah.
sometimes
Yeah.
to get a fresh salad.
Right.
Or,
Right.
sometimes people will say, well, that didn't really fill me up, because
Yeah.
they don't understand you need to have some protein. You
Right.
just can't have, you're not a
Yeah.
rabbit. You can't just
Right.
eat lettuce.
Right. Exactly.
So I think we do need to emphasize. And I think one of the things that we don't know yet is how ultra processed foods, how hormones in our foods
Right.
are impacting our health.
Right.
I think that's a big area right now that people are starting to look at.
Right. Recently a paper came out which talks about increasing breast cancer and other cancers in young men and women under age 50. And even the mortality is actually going up in younger women with breast cancer as opposed to older women. It's decreasing, which is great to hear. But I think a lot of things, obesity plays a huge role, our environment and the pollution in the environment plays a role. And then I think the diet really.
Colorectal cancer especially,
Yes.
I mean, if you're eating an ultra processed diet, you're not getting enough fiber.
Right.
It's one of those things that it's difficult to
Yeah.
get fiber in your diet. I think it's easy to say, well, have Metamucil, twice a day.
Yeah.
That can increase your fiber intake. But so often if people are doing like protein shakes or smoothies and they're trying to eat healthy,
Yeah.
they lose that, the whole food or the whole
Yeah.
fruit,
Yeah.
component of getting fiber.
Oh, yeah, absolutely.
So I think that's why we're seeing, younger
Yeah.
people with GI issues, which then, maybe the constipation, maybe the diet. lead to colorectal cancer.
Yeah.
So I'm glad like the screening age has dropped
Yes, yes.
for colorectal cancer. And I know ACOG, American College of OBGYN, American College of Radiology, had always recommended breast cancer screening starting at age 40, every 1 to 2 years, depending on family history. But the
Yeah.
US Preventative Task Force sits
Yes.
at 50.
Correct.
And I'm preaching to the choir. You know much better than
Yeah.
I do. But I
Yeah.
think that, that's critical in terms of early diagnosis, right?
Yeah. So recently they just came out and made a statement in JAMA. They actually dropped it to 40,
Mhm.
to 75. So between 40 to 75. What I'm still not happy about is still every other year and not every year.
Yeah.
And they don't really talk about dense breast and things like that.
Mhm.
They do mention African Americans are 40% at higher risk of dying from breast cancer because they do
Right.
have such aggressive disease at younger ages. So there's still more work to be done, but the fact that they dropped to age 40, that's a really good
Yeah.
progress, good step. But we follow NCCN guidelines, National Cancer Comprehensive Network
Mhm.
guidelines, also same as the ACOG, which recommend screening mammography to start at age 40.
Right.
Assuming you're not at high risk or you have family history of breast cancer. If you have family history of breast cancer, then the recommendation is 10 years sooner than the family
Mhm.
member who's diagnosed. And one other point I'll make on breast cancer screening is it's really important on the same topic of younger women who are getting diagnosed under age 40 when there's no screening recommendations. There's what's called breast cancer risk assessment, and that's
Mhm.
done by either primary care or OBGYNs or breast specialists, where they plug in their numbers, their age, when they started their periods, how many kids they have, and family history of breast and ovarian cancer. It gives you a number. And if you're more than 20% lifetime risk of developing breast cancer, you can be followed with an MRI and a mammogram. So you don't have to wait till age 40. So again, it's
That's awesome.
really important for
Yeah.
our listeners to know that,
Yeah.
know your family history. And oftentimes as Asians, at least my family, we don't ever talk about like cancers. When I was diagnosed with cancer, my mom is like, don't tell people. I'm like, well, I'm gonna
Yeah.
go on the Today Show and tell everyone, because people, it's important to talk about these things.
Right. And I think that's
Yeah.
true for so many things, like when I ask patients, when I'm getting a history from them, whether it's because they have heavy periods or because they have painful periods, or like you said, genetic family history, just kind of finding out like, oh, did your mom have really bad periods? Did she have a hysterectomy? Did she have surgeries? Because you can learn a lot from that, and that can
Yeah.
help you guide sort of your counseling to the patient or what you look for yourself,
Yeah.
when you're trying to make a diagnosis. I mean, where we see, sort of underdiagnosis and just dismissal of symptoms are endometriosis,
Yeah.
fibroids.
Yeah.
There is, what's amazing too, is there's a federal bill. They're increasing funding
Oh,
now for
wow.
those
Okay.
issues, specifically for fibroids. But again, there's an ethnic component to that. There's a genetic
Yeah.
component to that.
Yeah.
And we don't really know, like,
Yeah.
what are they? We know that fibroids tend to grow, with pregnancy, or they grow in certain circumstances where there's more hormonal
Yeah.
stimulation.
Yeah.
So perimenopause, for example, when your hormones are kind of up and down,
Right. Right.
that can increase those symptoms, like the heavy periods, the
Yeah.
cramping, the clotting, the quality of life issues, where patients will say, oh my gosh, like there's 2 days of my period, I can't leave the house,
Yeah. Yeah.
And I guess that was a good thing in COVID when people were working from home.
Right. 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 Yeah. Yeah.
You could stay home and not worry
Yeah.
about, oh my gosh, my period's
Yeah.
gonna like knock me for a loop,
Yeah. There is a huge discussion out there about perimenopause and hormones. And what's your
Yeah.
take on that? I would like to
Yeah.
hear that.
So I think there's a false sense of fear when it comes to things like birth control pills, IUDs, hormone therapy. We had the Women's Health Initiative in 2002, which scared a lot of people.
Yeah.
That it was almost like the press reported it before there was a chance to really
Yeah.
research it.
Yeah. Yeah.
And so when we look what happened between 2002 and then 10 years, 15 years, even 20 years later, what we found is that the mortality rates actually went up for women who had a hysterectomy and had their ovaries removed at a young age,
Yeah. Yeah.
that weren't supplemented with estrogen, because estrogen plays a big role in terms of like your bone density,
Your cardiac.
cardiac risk factors. There is a little bit of an increase in risk for heart disease, but then over time that drops down
Yeah.
when you take hormone therapy. Same thing with breast cancer. The risk for breast cancer gets blown out of proportion
Yeah.
to the benefits of hormone therapy when it comes to short-term use,
Yeah.
where no one's recommending anymore that people stay on it for a lifetime.
Right.
Now, there are people who want to stay on it for a lifetime, and you have to have an informed discussion, but it is one of the best ways to address hot flashes and night sweats,
Yeah.
some of the changes that happen with menopause, like the vaginal dryness and the bladder urgency and frequency, things that you don't really realize are hormone related.
Right.
So I do think that, again, understanding perimenopause, things that people don't talk about, like, you ask women like, well, when did your mom stop having cycles? I don't know. We don't talk about that.
Yeah. No, those are all great points. Now, what do you recommend for women who, were breast cancer diagnosed, women who are hormone receptor positive? Would you ever consider hormone replacement therapy for them, for that group of people?
So it's tricky, right?
Yeah.
You have to have that informed discussion with them.
Yeah.
From what I understand, more and more people are starting to look at sort of that local use of estrogen.
Correct. Exactly.
That for urogenital atrophy, or, in layman's terms, what we call like vaginal dryness. And the women who keep having urinary tract symptoms, like they have a bladder infection, but their cultures are always negative, or they have that urgency and frequency. I think the local use, whether it's estrogen or DHEAS, some people are using testosterone topically, but there are some options in the hormone world that can help those women who've had breast cancer. But again, it's working collaboratively, right?
Exactly. Yeah. So I think for our listeners, I think the take-home message is, if you have had breast cancer, which a lot of our listeners are, and you're having issues with, vaginal dryness and hot flashes and night sweats and urogenital syndrome, it's important to bring those up with your providers, with your physicians, and talk about it, because there are things we can do, either local hormonal therapy or some other medications. Veoza seems to work really great.
Yes.
Also,
Veoza works on the neurotransmitters.
Yes.
So it's non-hormonal.
Yes.
And it's not in the classes like venlafaxine that also have been used in the past, the antidepressants. This is a brand new drug. It acts on the neurotransmitters in the brain. So it really has been a nice niche product for people, whether they've had a history of a blood clot or a stroke or heart attack, or breast cancer. There's those groups of women really can benefit from that. And it's not time limited like so many other things, where you tell people, okay, you should go off hormone therapy after X amount of years, or you should reconsider what you're doing. With that, you can stay on it for a long period of time. And sadly, 20 to 25% of women will always continue to have hot flashes, even into their 70s and 80s. So there is a subset of women that we can't automatically just take off their hormones at a certain age.
I have the hardest time in women who come to me already diagnosed with breast cancer, but they're on hormone replacement therapy for symptoms, terrible symptoms. And so when they get diagnosed, that's the time I have a discussion with them. I usually, have them stop their hormone replacement therapy. And then that gives them some time for the body to get acclimated to not having those hormones as they're going through surgery and radiation, other things. But I also start them on like venlafaxine or some other drugs to help them get through that time period before they start them on anti-estrogen medications. So
right.
These are all great really tips.
I think so much of what we do now is much more individualized than when I first
It's
started.
very
in practice.
personalized.
When I first started in practice, it was all about everybody gets hormones. And then it was nobody gets hormones. And now we've come to a place where we're understanding, sort of tailoring therapy, I think. And I think we see it, now with whether it's genetic, like biomarkers or tumor markers or things that you can then clarify maybe better what somebody's cancer needs to be treated with.
I think it's personalized medicine. That's what we're focusing on these days, which is great. And also the important thing is shared decision making. It's really important for us to collaborate with our patients and talk about their symptoms, taking time. And unfortunately, sometimes we don't have the time. And that's why I created this podcast called the Breast Cancer Podcast, where we can talk about these issues, where, our listeners can go back and listen to.
I love that.
I have a great episode on hot flashes. Please listen to that. If you have questions, I have 10 different strategies for it. So, all right, moving on to the screening. We talked about breast cancer screening. So I kind of want to talk about cervical cancer screening.
So cervical cancer screening has changed over time. we were actually probably over-treating, when we look back, because we started cervical cancer screening at 18. We started with everyone, regardless of whether they were sexually active or not. So now that screening guidelines are changing to start at age 21. The biggest thing we're recommending is the HPV vaccine.
Yes.
When you think about what can you do to prevent cancer, we talked a little bit about diet. We talked a little bit about managing
Yes.
weight, those types of things, or limiting your alcohol, not smoking. But honestly, there's so few things that prevent cancer.
Yeah.
And that HPV vaccine literally protects against 9 different strains.
Yeah.
So you get protection not only cervical cancer,
Yeah.
but some of the head and neck cancers that we're seeing that are HPV related, that
Yeah.
our ENT colleagues are seeing, or, other colleagues are seeing. So the good news about the Gardasil vaccine, when it first came out on the market, it was limited to women or girls between the ages of 9 and 26.
Yeah.
But we know that oftentimes women get HPV through their male partners.
Yeah.
So then we expanded HPV vaccination to both boys and girls between the ages of 9 and 26. Now we're recommending it up to age 45.
Okay. So between 9 to age 45, regardless of gender.
Exactly.
Okay.
And, sometimes parents are reluctant because they're like, well, my kid won't be sexually active.
Yeah.
But we talk a lot about cancer prevention.
Yeah.
People are afraid of cancer, rightly so.
Yeah.
So oftentimes if you can talk about those benefits, same thing that we do when we talk about, this is one that probably but maybe your listeners don't, is that we are now recommending self-injectomies at the time of abdominal surgery. So say, for example, I go in to remove fibroids, or I go in to remove a cyst, and the patient's completed their childbearing. They're not interested in future fertility. The recommendation is to remove the tubes to cut the risk for ovarian cancer anywhere from 60 to 70%, which is, again, amazing, because there is no screening test for ovarian cancer. Patients will come in and they'll ask, can I get a CA-125? And I'm like, that's not truly a screening test unless it's done in conjunction with an ultrasound.
Yeah.
And we know that you have risk factors because you have, 2 first-degree relatives who've had ovarian cancer. So it's not just because, as you know, CA-125 can be very nonspecific.
Right.
And you end up opening up a can of worms that maybe isn't necessary and creates unnecessary stress.
Yeah. So self-ectomy, which is removal of the fallopian tubes after women are done with their childbearing years, correct? And that does decrease the risk of ovarian cancer, because the thought process is the ovarian cancer starts in the fallopian tubes, correct? Is that right? That's such a great thing for people to know and ask their doctors, once you're done childbearing, and you want tubal ligation, whatnot, but to have the discussion with their OBGYNs. Thank you so much for bringing that up. And HPV, anyone between ages 9 to 45, whether you're a guy or a girl.
Right.
And my kids are vaccinated. I'm very grateful, because
too.
you just don't know. You just don't know. We think our kids are not sexually active, but you just don't know. Their partners could be. And so I think.
Well, and I don't even think of it in the framework of sexual activity. I think it in the framework of cancer prevention.
Right.
Like, what can I do to keep my kids safe?
Right,
We tell them to wear seatbelts.
Yeah.
We tell them not to smoke.
Yeah.
This is one more way that
Yeah.
we're keeping them safe,
Yeah.
regardless of whether they are or aren't sexually active.
Yeah.
But pap smear screening, going back to them, we
Sidetracked,
sort of digress there.
Yeah.
Truly, it's every 3 to 5 years, depending on whether you do co-testing with HPV. The HPV testing is routinely done after the age of 30.
Okay.
So at 30, it's a pap smear plus co-testing,
Okay.
regardless of what the pap shows.
Okay.
Before 30, if somebody has an abnormal pap, they will do HPV screening.
Okay.
But it's not something we routinely do, because young women who are sexually active oftentimes will test positive for HPV.
Oh, okay.
So you end up unnecessarily adding on additional costs then for colposcopy or more closely following them. So that's why we don't do it unless, if the pap showed some abnormal changes, then the pathologist would automatically do the HPV screening until they're 30. And then after 30, it's standard.
It's standard every 3 to 5 years. When do you stop getting pap smears, or is there an age?
So there is an age. Typically, it's age 65 for just routine screening. But there are circumstances, and again, this is like talking to your
Yeah,
doctor.
yeah.
Do you follow it into those risks of, have you had cervical cancer?
Yeah.
Have you had other risk factors that maybe you do need to be screened after the age of 65?
Yeah.
But usually that's when we stop screening. When people say, well, how can you tell? Like, are you going to miss a cancer? Usually what happens is that you have symptoms, right?
Mhm.
Like the person who comes in with bleeding after menopause, the person who maybe comes in with cramping or bloating, discharge, or bleeding after sex. Those are people that maybe need further evaluation.
Yeah.
And in that context, you may end up doing a pap smear.
Okay, I got you. Okay.
And a pap smear is not a pelvic exam.
Yeah, yeah,
A lot of times people go, I got a pap smear in the emergency room. And
yeah.
you're like, no, you had a pelvic exam.
Right, right.
They probably checked to make sure you didn't have any sexually transmitted diseases, but pap smears are not something the emergency room does as
Yeah,
a routine.
yeah.
So, and that's just an educational piece.
Right,
I think
right.
oftentimes it's just inherently people think a pap and a pelvic are the same
Are the
thing.
same thing. Yeah, yeah. Yeah. These are all such great tips. And these screening guidelines or recommendations keep changing.
Yes,
So
it's hard to keep up.
it's hard to keep up. So I'm so glad you're talking about it today. And HPV, I mean, that just is, it's amazing to have an option for preventing cancer, not just cervical cancer, but other head and neck cancers, which are actually going up in the United States. Colorectal cancer, like as you alluded to earlier, the screening age is at age 45, and they could also start with the fecal occult blood test, sigmoidoscopy, or colonoscopy, but the age has gone down. Lung cancer screening for women over age 50, the recommendation is to get the CAT scan, especially if someone has had 20 years of smoking history or higher. And so that's something that's important for people to know as well.
Well, and I think one of the things that I was surprised to find out too is that the non-smoking related lung cancers have gone up.
Yeah, yeah,
the adenocarcinoma, the small cell, like that is increasing because fewer people are smoking, right? But it's scary because again, the people I know recently who've had lung cancer, none of them have been smokers. And so you wonder, what is it? Is it something in the environment? Is it something in the pollutants that, I mean, we just don't know.
Right. We just don't know. Yeah. I mean, I used to say 85% of the lung cancers are from smoking and 15% are non-smokers, but I think the numbers are changing a little bit now. So, which is kind of sad. So in terms of talking about who is a good candidate for genetic testing,
I think you know that better than I do. I think, we should.
Yeah.
So in our field, when it comes to OBGYN, I definitely offer genetic screening or genetic testing to women who, for example, the family member has had, ovarian cancer or uterine cancer. I'm going to leave breast cancer for you to talk about, since you're the expert, but ovarian, uterine, those cancers, if they've had them, especially premenopausally. So the younger the age of someone who's had ovarian or uterine cancer, you want to offer more specific screening. And again, for ovarian, 2 first-degree relatives, doing the CA-125 plus ultrasounds yearly. You can, and again, you know better than me as far as like patients who are BRCA positive or positive, have had genetic testing and have Lynch syndrome or have any of the genetic conditions, then you may go ahead and offer preventative surgery.
Yeah.
And again, preventative surgery could be as simple as saying, okay, you're at more risk for ovarian cancer. Let's remove your tubes. And then once you hit 40 or older, then we can go back and remove the ovaries or the uterus if we need to. Because again,
just to keep those hormones on board still.
Exactly. Because if you take someone's ovaries under the age of 40 and you're doing it for preventative reasons, then do you then put them on estrogen? Do you put them on estrogen and progesterone? Like you start to have a bigger discussion in those women.
We strongly advocate estrogen, especially if they don't have a uterus. But the concern is the combination of estrogen, progesterone does increase the risk of breast cancer. And so that's always a little bit of a concern. I just recently operated on a 29-year-old. I with the BRCA mutation. And I said, you could totally wait. You don't have to have, surgery this early, but she opted for it, had a hysterectomy and her ovaries were removed, but she's going to be on estrogen. So,
Yeah.
so she will still get hormones, thankfully. But going back to who's a good candidate for genetic testing. So those people you mentioned with breast cancer personal history, if you're younger than age 50, or if you have two family relatives on the same side of your family, or triple negative breast cancer, or male breast cancer, Ashkenazi Jewish ancestry, those are all criteria for genetic testing. And you may want to ask your provider to referral to a genetic counselor, and a genetic counselor is someone who specializes in genetic counseling as well as testing, so they can guide you as to what kind of testing you would qualify for and how much the insurance will cover and whatnot. I just recently came back from a conference. They were recommending testing everyone because we are not diagnosing. And I don't know if you're quite there yet, but if you definitely have family history, you want to talk to your provider.
I think that when we start doing this like shotgun approach, we tend to then end up over-treating or creating more panic.
Right.
So
it's anxiety that can cause.
And I think for, when you think about mental health, like some people do very well with knowing, like, knowledge is power. Other people find it very scary and stressful. So I think you do have to have the discussion.
And you have to,
it,
figure out the patient. Some patients, I mean, even with the breast cancer diagnosis, some people are like, it's, early stage cancer, let's get rid of it, lumpectomy, whatever, let's go with it. Other patients are scared for the rest of their lives. They're thinking about cancer coming back. And every person is different. Our anxieties are kind of based on where we come from and the experiences we've had and all those things. But going back to the genetics too, the most common genetic syndromes that we talk about is hereditary breast and ovarian cancer and Lynch cancer, or Lynch syndrome. And so that's, the hereditary breast and ovarian cancer is associated with breast and ovarian cancer, pancreatic, prostate cancer. The Lynch syndrome is colorectal and uterine. So that's important to know. And any other screening recommendations that we didn't cover?
So bone density.
Yes.
I know that a lot of the breast cancer patients will get screening early on because they aren't taking estrogen or they've had these surgeries that impact their bone density. So typically osteoporosis screening or the DEXA scan, it's a very easy, you lay on a table, they check your hip and your spine and give you a T-score, which then tells you what your risk is. That's recommended starting at age 65. Unless you have specific risk factors. So I think, again, having the discussion, learning, like, are you a long-term smoker? Were you on steroids? Do you have a family history? A simple screening is just checking someone's height once a year. Like if they're starting to shrink a little bit, that may be someone that you want to offer testing to sooner.
Absolutely.
But that's, I think we've covered a lot of
We've covered a lot. Yes.
Healthy.
Just, I'm going to throw out a couple of things just because I looked at all this up before the podcast. Is blood pressure screening for high blood pressure starts at age 18. I didn't realize it was that young. And then cholesterol starts at age 20. So
again, diet, right?
Right, exactly. And the diabetes at age 45. I was thinking we should screen earlier than age 45, but that's what they're recommending.
I think, again, diabetes is very specific. Like women who have had a pregnancy, they get screened during pregnancy with the gestational diabetes. And if somebody's a gestational diabetic, then we screen them again when they're not pregnant. So that seems late. I agree with you, but we do catch a lot of women earlier because they've been a gestational diabetic, and then we follow them postpartum or, to recheck them after their pregnancy's over.
And then if they continue to be diabetic, you refer them to endocrinologist.
Right. And again, ethnicity, right? Like Indians are more at risk for diabetes. You have American Indians, East, and what am I trying to say? Asian Indians.
East Indians.
East Indians.
This is something I do want to recircle on this topic at some point. We do have diabetes and heart disease in our family, and I think the East Indians, we really are not we don't have the awareness of the impact of the diabetes and heart disease. And also I have learned that the blood vessels in East Indians are super small, so it doesn't take very much of plaque buildup, whether it's through diabetes or heart disease, and cause problems. So cause cardiovascular issues. So I do want to circle back sometime, not only talk about breast cancer, other cancers in Asian Americans, but also diabetes and heart disease, because it's a different set of a group of people. We have always thought we are not as obese, so we're not going to get these diseases, but it's actually, it's a silent killer. And
well, and in that population, the weight really doesn't seem to matter.
I know, and I don't understand that.
You might see someone who's super thin and you look at them and you think they're healthy. And, it's that term that people call skinny fat, where unfortunately you could look like you're super healthy, but your genetics throw you into a different risk category. And I think, and again, going back to the polycystic ovarian syndrome, we do see that more in Asian Americans. So that is another sort of tipping point of looking at what was their past history. Did they have fertility issues? Maybe they had PCOS that was undiagnosed. And, or they, looking at their pregnancy history, like we talked about, to then predict kind of like, okay, maybe this person needs more closer screening, more education about diet, because Indians in general, Asians in general, tend to eat a lot of rice. It's a very starchy, kind of carb heavy diet.
I'm my mom actually has been diagnosed with all this, so I'm very passionate to hear about this and help other people. And I think when we go through situations like this, our job is to not only help ourselves but help others. And I really appreciate you doing that. One last thing we'll talk about screening is skin cancer screening. Yes, and so it's important to wear SPF sunscreen with SPF, what, 30, 40?
35, 35 minimum. But I think a lot of people are good about putting sunscreen on. They're not so good about repeatedly reapplying. And I think there's a misconception that because you have more melanin in your skin, you're less at risk for skin cancer. You're still at risk for melanoma. When you think about melanoma as one of the more deadly skin cancers. So definitely the idea of screening, looking at moles, things like that. But no matter what your skin type or color, when you look at the 1 to 5, the different skin tones, everybody should be wearing sunscreen. And again, I kind of jokingly say, well, it's not just about skin cancer prevention. You don't want to end up with a bunch of wrinkles.
I know, right? Same, That's my reason for wearing it.
Seriously, the sun is so damaging to your skin.
It is.
And so being aware of that, I think, is another sort of vanity thing. But
hey, it works.
It works.
Right? So, well, we're going to wrap it up here. And we talked about really a lot of great topics and screening. We talked about breast cancer screening, cervical cancer, colorectal, skin cancer screening. We talked about who is candidate for genetic testing, counseling, etc. And in ending, make sure you're keeping up with your Wellbeing exams, talk to your providers, be active. American Cancer Society recommends 30 minutes a day, 5 days a week, or 75 minutes vigorous activity. I say do something every day. And as simple as walking. I find walking to be so therapeutic mentally. And it's a place where you can be with yourself, with your thoughts, and try to figure out life, because there's always issues and things that are going on in our lives, even without any cancers, right? So and
mental health.
Mental health is such an important topic. In healthy, balanced diet, we talk about it. And I really think, especially like what I have learned in my own life, is planning your diet. So, like this
food prepping,
planning, I think it's really important, figuring out what your week is going to look like, and, prep for that week. And then figure out ways to cope with stress.
I think one of the things that I've noticed is people think they're eating healthy because they eat granola, or they eat, those power bars or protein bars, or, yogurts, but the yogurt is full of sugar because they're getting the sweetened yogurt. So I think that one of the things I really try to encourage people is to try and do, Whole Foods, not the grocery. I'm not marketing any grocery store, but Whole Foods, and 80% of the time, keep up with a well-balanced diet. For the 20% of the time, if you cheat, it's not the end of the world.
Correct.
You don't want to feel like you're depriving yourself constantly.
Right.
And, alcohol, that's one of those things that sometimes people are like, oh, red wine, it's good for your heart.
Yeah.
Other times you read, oh no, no alcohol is good for you.
Yeah.
And again, it's confusing.
It is confusing. Yeah. The guidelines keep changing. Yeah. We say in the breast cancer world, less than 2 drinks a week is kind of, and that works because typically we're not drinking on weekdays, which hopefully we are not, because that just accumulates to be a lot of alcohol. And so 2 drinks a week or less is kind of what we recommend in the breast cancer world. And, no smoking.
Of course.
Yeah. And sunscreen and, lots of water and fiber intake. These are all like simple things, but, you have to be very purposeful.
Right. So the other thing I think that we don't talk about a lot, but I think is really critical to mention is vaping.
Oh, yes. Yes. I was
So,
just going to talk about that. Yeah.
There is an assumption that vaping is safer than smoking cigarettes.
Yeah.
But again, there's so much damage that's happening to the lungs and in young kids. So I would say, put vaping into that same category. Like, don't start, don't vape, it's bad for you regardless of how little or how infrequently you do it.
Yeah.
But again, there's just not been a lot of information out there about that.
Exactly. Exactly. Actually, I've heard anesthesiologists talk about how difficult it is to intubate these patients, and they have lung cancers that are, being diagnosed much early.
Well, and they're getting a lot of the fibrosis or scarring that is affecting their lung capacity.
Right. Which is like, it's not reversible. It's irreversible damage to the lung.
Well, and again, now that we know marijuana is now legal, because of the constitutional amendment that was passed last year, you have to look at that too, as far as there isn't a lot of research and data about marijuana and how it impacts. But again, we know that it's the carcinogens that impact your risk for lung cancer. So probably marijuana smoking will fall into that same category, as we start doing more research in the area now that it's becoming legalized.
Yeah. I agree 100%. I think we have to wait to see what the research comes out on that, as we don't have robust data, but I would not be surprised with that. So, well, Dr. Somani.
Stick to gummies. I don't know.
I know.
I'm not going to say that.
I know.
I'm not supporting it, but I think that we're finding, that there are areas in terms of marijuana use that can be helpful.
Right. I mean, absolutely. There's patients who are, have difficulty gaining weight and, different things like that. And that has been, one of the areas that we do advocate for them to be using the gummies. So this has been a great conversation, Dr. Somani.
So it's so fun. Dr. Halaharvi and I run into each other, and it's just so fun to see her. Whenever I see her, I'm like, oh, I learned something new, or I felt better walking away.
Well, I 100%, I ditto 100%. I feel the same. And you're such a great role model for us, like all the advocacy work you're doing and helping people in our community. And our community is so blessed to have you here. I am super blessed that you're here today. And your podcast that you did with me, maybe a couple of years ago now, is probably the top most listened to podcast. So I think this is going to be
you help me tell patients to listen to it.
I'm like, you better listen to Dr. Somani's podcast. Otherwise, no. But no, the information that you provide for our listeners is so invaluable. And I really appreciate you. And I hope our listeners take advantage of this information and talk to your providers. Obviously, you have to, have the shared decision making, and and good luck with everything. And we keep empowering each other, and and that's what life is all about. So
it is.
Yeah,
it's just living healthy,
living
life the best way you can.
Yes, and living your best life. Yeah. Thank you all very much for taking the time to listen, and we'll see you next time. Bye. Thank you, everyone, for tuning into the Breast Cancer Podcast. Remember, you're not alone in this fight. I encourage you to be an active part of this podcast. Please share your stories, questions, and suggestions for future topics at my website called drdeepahalaharvi.com. And please share this podcast with others, especially if you found it useful. And please also give it a 5-star rating, if you will. Stay connected as we navigate the complexities of breast cancer. Until next time, take care and keep shining brightly. Disclaimer, this podcast is not intended for complete medical advice.